This talk is about the CONSORT statement and reporting research responsibly. I think, I'm glad I'm doing this talk because it's the last talk we're doing, and I think I probably picked what is likely to be the most boring topic possible. So I think it's good that I put myself in this position. But I'm going to do a couple things with this talk, and it's not all going to be about the CONSORT statement. So we'll see how it goes. We may finish early, but we may not. So I funded from various places. None of them currently make me feel too dirty. So what I'm going to try to go through is a quick evaluation update on how we've been doing on the evaluations. There's no interim data from this morning, but I'll show you where we are in recruitment in terms of completion of evaluations. Then I'm going to talk about a little bit of a background of science and where we're going with clinical trials. Talk a little bit about CONSORT and its extensions. It was pointed out to me last night that I did not provide significant coverage of acronym development. So this is one of my roles at NET is sometimes developing acronyms, although Robert Silverlight is actually my primary mentor in this area as he is masterful. So okay, here's the evaluation update. Here's how recruitment is going. We have, as of last night, 0 evaluations of clinical trials Jeopardy, which was the most awesome session ever. So, and Kurt and Michelle's talks were all obviously quite good. So the more we can get in terms of evaluations down here. But as you can see, this is, for all intents and purposes, a downward trend from the very first talk. So I understand that it's a lot of clicks, and I've been asking you to do a lot of clicks. I'm really glad that we have 256 evaluations so far. Obviously, there's some repeated measures issues here, but we will really use this information to help make the course better. And what we're going to do, after my talk, it says time for some evaluations. If you click the box for overall course evaluation, you will be very pleased to learn that it asks you some different questions. So you don't have to click the same boxes. It's actually mainly 5 text boxes that ask you about the strengths, weaknesses of the course, some opportunities for the course for improvement, and what the major threats to the course, what would sort of threaten it from doing well for you. And then also a question about how you ended up finding out about the course so that we can learn more about how we can reach a broad, inclusive audience next year. So, and then while you guys are doing that, I'll give you like a half hour or so to do that after this. Myself and the other core faculty members, we'll go out of the room. It's almost like a college, like the professor would have to leave the room, and one of the TAs would sit there and hand out the evaluations. They still do that in college. They didn't evaluate any of them.
I don't remember that.
I had to work as a chemistry TA at Ohio State. And the ironic thing about me in Michigan and Ohio State is that I am a huge Ohio State football fan, and that is all right. So to switch gears, has anybody ever read the articles by John Ioannidis? Or even read some of those articles that sort of feature this in the more popular press, like The Atlantic? So this is what we're trying to avoid. We want to have some flexibility in how we develop clinical trial designs, some introspection, some thoughtfulness. But this is a paper that he had published in PLOS. And it's basically a modeling framework in terms of thinking about, as when we do clinical work for those of us that are clinicians, we think about this sort of pre-test probability of disease. And this takes this approach, which is a very Bayesian approach. And this takes this general approach of the pre-test probability of a research finding actually being true. And this is actually conditional upon the fact that anything that we've discovered is really true. We're really making estimates. Some scientific processes we're more sure of than others, but some of the first research that I did, the first thing that I did, I don't want to digress too much into a professional autobiography because I will not end up finishing on time. But the first thing I did when I started at Michigan as a fellow, and mind you, I had classical training in biostatistics as a resident and medical student, which meant it was 2 days in the last row of the lecture hall at the University of Cincinnati Medical School, and I kept hearing about this, this alpha error and this beta error. And the instructor was actually Lebanese, so he was trying to say beta, but just he's saying beta. And I kept thinking, I was like, I don't get why that error is any better than that other error. It doesn't make any sense. And that was all I remembered about learning biostatistics. I certainly didn't learn anything in residency. Then I show up, and Philip Scott and Robert Silverglide are like, hey, we got a database. You want to do some analysis on it? I was like, oh yeah, I can do some logistic regression. I can find a little form for this, and actually I did logistic regression, and I found that there was not so much an association between hyperglycemia and clinical outcomes in these stroke patients from a cohort that Philip Scott had developed, which is interesting. It goes against a lot of other data, perhaps some things that are underpinning a clinical trial that I'm very much in support of right now, but it was what I observed. And so I've taken an approach that any time that I go into a data set and analyze it, even if I have to submit it to 15 journals, I publish it. So, and I do have a lot of publications, but I was sort of looking, sadly, at the number of times many of my publications have been cited as last night on Google Scholar. So, but anyway, the idea here is that because that maybe not everybody would have been so persistent. I mean, initially I submitted it to the stroke meeting 2 weeks after I started my fellowship in stroke. Needless to say, it was rejected there. But then I submitted it to the Mediterranean Emergency Medicine Conference, which as it turned out had different standards. And I was a top 10 abstract there. And then Bill Barson, and I was like, Bill, I got accepted to this. It was like, I have to go to Sorrento, Italy to present. He's like, okay, that's fine. So it ended up being good for me. And it was not the first thing I got published, but it is something that I did ultimately get published. So, but this is you know, one of the things to think about is that everything that you see in the literature that's underpinning what you're using is your basic science justification, your preclinical science justification, your observational epidemiologic observation. People all over the country who are looking at data both in the preclinical space and in the clinical space are making decisions about that. And many mentors would say, if you find that hyperglycemia and outcome in thrombolytic treated stroke patients is not well correlated, it might not be a winning strategy to try to beat yourself down and keep trying to get that published. But the people who told me that were possibly right, but I just wasn't ready to listen, and I did get it published. So but the thing is, the medical literature as a whole has some quirks to it, and the idea here is that as you move forward, because of the sort of pre-test likelihood of a finding in a research study being true is dependent upon the whole process that got you there, it's something that's important to consider. So, how many people know this? This is just a fun little pre-test probability type example. How many people have seen the Monty Hall problem? Have you seen it? You've seen it. Okay, who like really raise your hands. Okay, so you don't, when we ask people, why did it just go forward like that? Is it said to just go? No, don't go. This is what happens when you borrow slides from the internet. So, stop. Don't go. We'll see if it doesn't go. Okay, so, did anybody ever see this TV show?
Yes.
Okay, so the idea here is, let's see if I click once. You're given the choice between these three doors, red, green, and blue. Behind one is a car, behind the other two are goats. You pick the red door. So the guy, Monty Hall, so you don't move again. So the Monty Hall knows what's behind the other two doors. So once you pick the red door, he opens one of the other two doors and shows you a goat. You don't really need a goat. You need a car. And so he shows you that. So now that you see these two doors, you initially pick the red one. He asks you, okay, I showed you a goat. What do you want to do now? Do you want to stick with the red door, or do you want to move to the blue door? So what should you do? And for people who've already solved this problem, don't solve it. Okay, so how many people want to stick with the red door? Raise your hands. Raise your hands high. Okay. How many people want to move to the blue door? You gotta make a choice. Have you ever heard that Rush song? Sing it. If you choose not to decide, you still have made a choice. Okay, so if you choose not to decide, you still have made a choice. All right. It's too bad Scott's going.
You realize that your evaluation is like shoot to the top.
I know how to. Yeah, right. It's special answer. We haven't done enough evaluations. Do evaluations.
Could have been
Okay.
singing.
So what do people think about this? Why would those of you who didn't switch? Why didn't you switch?
I think the odds are the same.
Are they?
I don't know.
For those who did switch, why did you switch?
Probabilities change.
Probabilities change. So right, the odds are not the same because Monty is standing behind there. He knows where things are. He wasn't going to open up the car. So that's information. You got information. The door was opened, and there's no car behind it. But he wasn't going to open the door with the car in that phase. He was always going to show you. He's always going to show you what goes. So your information initially, you're right. There's a 1/3 chance on each. But because you've gotten new information, and this is what we do, and this is why we do research, we update our existing information. But we've changed these post-test odds. So if this is Bayes' rule. I'm not going to show a lot of equations, but the idea that this sort of spells things out. The probability of the prize in red if host picks green, the probability of the host picking green if the prize is in red. Basically all of the probability of everything. And if you multiply these things together and you multiply it out, you say you start out with it being a third, a third, a third. Then as things change, you multiply all these out. There's no chance that he's going to open up a door that has a car behind it. So you update your probabilities, and if this doesn't make sense, and I am not a statistician, so I always have a bad time making this make total sense to people, but take my word for it, you have a 2/3 chance of winning if you switch, and a 1/3 chance of winning if you don't. And if you don't believe me, look on Wikipedia, then I'm sure you'll believe me after that. But the idea here, and the lesson, is that every time we get more information, it changes the odds of something being true, in this case, research. So it says that you want to switch your pick every time. This is one of those things about probability that is not intuitive to us as clinicians. And part of it is perhaps not fully appreciating that the guy behind the wall has some information. And because he has some information, it sort of changes the situation. And adapting to how the situation changes is important if you want to have a better chance of getting the car. You're still not going to get the car every time. Sometimes you're going to lose in that strategy, but you do improve your odds. I don't know why it's just going along with this. But maybe it's trying to keep me on time. So in the NINDS article, they looked at the idea of positive predictive value in research finding based on various designs. And this ratio R is what is the estimated pre-test proportion of studies that are true versus studies that are false. And the idea is that adequately empowered randomized controlled trials with little bias and about a 1-to-1 pre-study odds, meaning that you think there's about a 50-50 chance that the study is going to yield a true result based on the disease in the study. 10% bias means what proportion of the design data analysis and selective reporting are resulting in stuff being presented that shouldn't have in that space. You get a positive predictive value of 85%. So of findings of research in clinical trials that are in the late phase, where there was about a 50% pretest probability of something being true, your positive predictive value of that really being true is about 85%. So that's pretty good. But as you can see, as you go down to other types of research designs, including the random performance of logistic regressions on data sets your friends hand you, the positive predictive value of those findings being true goes down substantially. So the idea here is not to like freak out and say, well, why should I be doing research? It's just to appropriately understand that every time that you're doing a data analysis and you're reporting something, it's not, you have to think about it within the proper biological context. And the idea of the clinical trials that we're hoping that you're designing is that you help move things along in this way, in a way that you can learn efficiently and effectively, and sort of, and when you go into things with a biologically driven hypothesis, your chance of, and make sure that you publish them and that those results are shared, your chances of contributing to the overall bias in scientific literature are low. And your chances, I think, of coming up with a result that is as true as possible are high. And hopefully will underpin the phase 3 trials in the future. So that's, that's the just sort of general warning that all, most published research is quote unquote false, except for, negative research. You can't prove a negative. But I think if you do an analysis that leads to neutral results, it's important for that to be out there in the world. Any questions, and I'm not like saying that I expect all of your clinical trials to be neutral. Again, that would be a really bad run of things. But if you had planned for and you knew what to do with neutral results, what your next step is, what your next scientific move is, again, this was pointed out by Chris in the first talk, is that pharmaceutical companies have development programs, and that if this drug isn't going to go forward, here's the next thing we're going to do. And I think as clinician investigators or non-clinician investigators, I think we have to think of ourselves as having those programs that we need to know what the next thing we're going to do is, the next area of science we're going to go to in our specific disease area, so that even if we have neutral results, we know what we need to do next afterwards. Does that make sense? Any questions right now? Yes, Andy.
So I've got a question about a similar list that the one that came up recently. So I had a student working on a data set. They did a retrospective analysis based on some reports of imaging from a data set, right? And so they were originally given a bunch of imaging results, but knowing that there were probably twice as many imaging results in another data set from the same population. So they talked to the biostatistician, they went ahead and analyzed the first data set, intending then go to the other full data set and add that in and do another analysis. So they get one result. Should they publish the first result, or should they combine them together to do control comparisons, or should they publish them separately? You see what I mean? Does that make sense?
Ideally, I think if they knew that they were going to be going for that other data, I would have liked them to come up with a plan in advance as to how they were going to deal with doing the sequential analyses. If they hadn't, one of the issues is if their decision to perform the second analysis was determined by what they had found in that first analysis, then I think we're getting into a bit of the multiplicity space that Michelle was talking about before. And I would say it depends. One of the things that I think sort of is an internal dream that will never happen, but what I have started to do when I do research that is not in the space of clinical trials is I write out a protocol as if I was doing a clinical trial, and I make a Google Doc that has a timestamp with it. So that has that. So it's always like, well, did you really, didn't you just look at 1,000 things and come up with this idea? It's like, no. While I could have done that, I actually had this one idea, and this is what I came up with. I mean, if you have access to a data set in advance, you could always timestamp that after you've done your initial look. Doing a survey study, a randomized survey of people in the emergency department, similar to the response adaptive randomization study that Josh referenced. And again, I'm prospectively collecting data, but I published, in a document, a timestamp document, everything that I was planning to do in advance. So I guess it would be nice if there was some sort of repository like clinicaltrials.gov where you could plan your analyses and observational studies in advance, so that you've at least set down, this is my analytic plan for this, and this is what I concluded, as opposed to sort of a random walk of, I looked at a bunch of these imaging things. From this first look, I found some interesting things that met whatever biological hypothesis that I sort of constructed to describe them, and then I worked on confirming them in another data set that is perhaps a correlated data set. I guess if you had that prospective plan as to here's how I'm going to use the data from the first one to inform the other one, I would say that there would be more rigor in that. I know it's not, I mean you could take the alternate approach is the data are what the data are, and if they're showing this relationship, that's what it is. I don't know, I'd be interested in sort of the thinkings of others in the audience as to what to do in that situation. I don't know, Lori, what would you do? You're not going to do imaging research. Avoid imaging research. Never do imaging research.
I'm a peripheral neurologist.
She's a peripheral neurologist.
It does involve radiologists.
What do you think, Sean?
Well, I think your perspective plan is the best. You know, I mean, what you originally proposed was the best way to start. Is to think about it ahead of time, because then you're less likely to just come up with spurious relationships that never can be reproduced. I think what you've encountered is very common, and I think that happens all the time, and I think that gets published all the time, and details are included of how you came about doing it. I would, and I guess I didn't catch the full details on what the difference was with the second data set, and why you didn't have it at the beginning, and how it came about later. But if you do go ahead and publish it, I would be very clear about what you did, and that this is, and if that paper that's in the readings on the multiplicities kind of gives you something. You can say, okay, this is what we started with, we saw this, and then we decided to do this other data set. I mean, there is credence for replicating a result in a different data set, but I didn't understand what it is really two distinct things.
It was really, the first group had CT angiograms, so that data was available, and the second group had MR angiograms, but they both could give you the same ultimate. So that was sort of how I came to. They're obviously not the same because they're two different radiological surrogates, but they ultimately contain the same information. So that's how they got
Are the same subjects or?
Yeah.
This is no,
Different
it's
subjects.
different subjects, yeah.
I think within the limitations of any observational research study, I think you say, here's what we did, here's how we came about it. We used this to derive the major hypothesis for the second set. They're different imaging modalities. This is what we found, but it's still in the observational space, right? And we learned about the Women's Health Initiative and how the observational space can be harmful because, again, unless you're doing them on a completely unbiased population, maybe the stroke clinicians are sort of getting MRAs in different patients. So it's observational research. And what I would say is that as long as you're transparent about how you arrived at that, I think it's okay.
Just being honest in the methods.
Absolutely,
Yeah.
you're totally honest in your process. And one of the things when you have situations like this, and you went through and did like statistical tests, statistical modeling, because I mean there's something else to be said for starting descriptive and things and not going through testing a bunch of things. So sometimes in observational studies, it's always good to have your hypothesis ahead of time, but sometimes descriptive summaries can be as invaluable as going through your statistical tests.
I do methodology statistics reviews for an emergency medicine journal. I guess I should disclose that. They pay me $50 a pop, right? So it's a big money maker for me. But that comes up commonly. People are doing purely sort of observational, like sort of descriptive stuff, and their aim is we're doing an observational descriptive thing, and then they do like 50 logistic regressions. And I was like, well, you had a bunch of in chi-squares. It's like, well, even though you said you had no hypotheses, you just did 50 hypothesis tests. So either you had one in advance that really was your main one, or you didn't. But the interpretation of multiple hypothesis tests in the setting of an observational descriptive study is something that I think you should be careful about. And I think if you're very in the way that it's reported, you're like, we're doing these exploratory analyses. It's hard to say what the significance of these are. I think you're on good ground. But if you sort of report, we looked at these 8 billion things, and that we found this. This is an interesting biological effect that requires confirmation. Maybe it's interesting, maybe it's not, but it has to be in that context of it was performed in the midst of a fishing expedition.
You include the emails when they're constant.
And that's something that sometimes it's just a poorly phrased manuscript, and they really did have a plan as to what their main thing was first. And it's like if you can sort of justify to me that you were really looking for this first, then I think it's okay to highlight that in that way. But if this was inductive, you came up with this from the data as opposed to deductive. You had a hypothesis before you looked at the data. I know it seems rather artificial because the data are what the data are, but to me it matters.
So you made a point that I just think is worth repeating. So a p-value is based on a hypothesis test. it may not be related to your main hypothesis, but it's still a hypothesis test. So I did one manuscript review where I commented on the fact that there were like 100 p-values in this article. And I commented on this, and we did all these hypothesis tests, and they said, no, we only have one hypothesis, it's this. Okay, but you did the subgroup analysis, the baseline comparisons, everything had a p-value associated with it. So just keep that in mind.
And there are institutions that require IRB review for retrospective chart reviews, kind of these retrospective, or, observational studies, retrospective analyses. And in that case, you have to have a protocol, and therefore you have to have a rigorous pre-specification before you go ahead, which is always a nice thing.
And as Roger pointed out when he was looking at sort of high-risk research, when they were submitting an EMS study to like 100 IRBs across the country to see what 100 IRBs would do with high-risk research, the degree that you might get a legitimate, this is unethical methodology back from an IRB in a minimal risk research setting of some thoughtful, if the IRB person, the person who's reviewing your application is thoughtful and has some statistical background, they might say, this is, the benefits to the subjects here of having their data access are not outweighed by the risk of your completely bonkers protocol. But I've found that our IRB is so busy that they're not a statistical consultation service. So if it's not within a zone of complete horribleness, they're probably not going to say you can't do this.
And different IRBs have different, like some have scientific reviews ahead of time, and I've participated in those that had scientific reviews, and at that point I would bring up something like, you're getting all this data, what are you going to do with it? Not being overly restrictive, but just like if you're going to do this retrospective chart review and actually spend the time to get all this data and have a plan, make sure you're getting what you need to answer the questions. It's kind of the approach I take on those kind of minimal risk reviews.
Those are good thoughts. I should have taken more time for this session. Now I'm running out of time. All right. Well, so I thought that I would not have nearly enough things to talk about in this talk. But one thing that I wanted to show you as a sort of halfway point in this talk, sort of lighthearted thing, just because this is maybe you've been sitting in this room a lot of times. So I thought I know that I made all of you guys do elevator speeches about your projects. So I thought that it would only be fair for you to see an elevator pitch that I did at the Neurologic Emergencies Treatment Trials Network retreat last October. So you can see how I would present a research idea. And by way of full disclosure, NET is not currently developing this idea. Let's see if this works. Wait, use the microphone. And I'm not going to play all 18 minutes. I'll just play the first 3. Can you hear that?
I'm Meurer from the University of Michigan. I really want to thank the organizers of the TED conference for inviting me here to speak today. This is a tremendous opportunity. So without further ado, we shall begin. This very instant, thousands of ambulances are circulating around the world, carrying one of the most potent neurotoxins known to man. Oxygen. What are we going to do about it? So on the schedule, I think this is listed.
Okay. You can't hear? Okay. So what I said, I'm not going to do that, was my basic pitch was that a bunch of ambulances were roaming around the world carrying oxygen. We're putting a lot of oxygen into people's brains, and as such, hurting. All right, let's just move on. I'll send you the link. You guys can watch it.
What's the teaching point?
There was no teaching point, actually. So the idea was that out of fairness, since you guys all had to, I think one of the things you had to do that was a bit out of your comfort zone is sort of justify your scientific idea within this sort of 2 to 5 minute approach, the idea of the elevator pitch. And in our small groups, we had to do that over and over again when somebody new would come. When Marianne was in our group, I said, give a quick little speech about this. When Vanessa was in our group, I said, give a quick little speech about this. As it turns out, you guys all got a lot better at describing scientifically what it was you were doing and why. And I think the idea here is that I do this too. I don't know if I did a very good job, but from a fairness perspective, I thought it would play a little louder. and it's kind of amusing. And I like to hear the sound of my own voice. So it was there's no real point other than I thought this was going to be a kind of dry lecture, and I wanted to throw something in here that was less dry.
Okay.
So I came back to the dry stuff. So the CONSORT statement is really important. And actually, that no joke, all levity aside, the CONSORT statement is really important. And if it isn't something that you've read, it's something that you should read. And even though it's mostly oriented towards 2-arm randomized clinical trials, and we're telling you mostly not to do 2-arm randomized clinical trials, many of the tenets of this apply very importantly to the research you're doing. And it makes for a decent checklist. And it's one of those things where if you come to the end of your clinical trial and you haven't looked at this checklist when you're planning your protocol and planning your data collection and your design of your experiment, then it's too late. If you're like, oh, I didn't measure how many people dropped out, oops. I mean, then it's not something you're going to be able to put into this, and that's going to be a criticism. So it's best to not wait until after data collection to consult. And I think one of the things that's very important for many of you, we decry the sort of pain in the buttedness of doing screening logs in net studies and so forth. I think for many of your studies, the screening log is going to be really important to figure out which patients are actually qualifying for your research studies, because getting your population correct and feasibility, knowing how many people are actually going to be eligible for your research trials, is really important. And that's sort of one of the fundamental things about the CONSORT statement. As you can see when you make this sort of flow chart, how many people were assessed for eligibility. I think thinking about your screening methods within your institutions, how many people were assessed, how many people were actually eligible, this sort of thing, this rubric is really important, and how many people ultimately got into your trial, how many were analyzed. Again, wanting to analyze by intention to treat. So, again, we've seen that we've all read reports of randomized clinical trials. We've all said we followed the CONSORT statement. Some of us may have submitted papers that have this and go through the checklist as to where each of these elements is addressed. I think it's really important when you're doing the design of one of these things to look at this and just see if everything on here is something that you're covering, or making a justification as to why it's not applicable for your study in particular. The interesting thing about CONSORT is that you might say, well, I'm doing a non-pharmacologic intervention. It's really sort of tilted towards drugs. Well, they've got an extension of CONSORT that deals with non-pharmacologic interventions. So there's additional questions that describe, because that's something that comes up quite a bit. How are we blinding an exercise intervention? How are we describing the exercise intervention? And looking at how the these bodies from the CONSORT statement have recommended that you do this, I think is really helpful. Now, this is not to say, this maybe gets at like cookbook clinical trials. And, I'm not saying this is cookbook clinical trials, but at least if you think about all these things that consistently have been identified as methodologic issues in clinical trials, and try to do your best to think about them in advance so that you're not another, if they go back and look, we looked at 1,000 clinical trials, only 2 of them reported this, even though it's a really important thing. You don't want to be in that sort of numerator in that sort of study later. So I think thinking about that. Other interesting extensions of CONSORT, I wasn't even really aware that they actually had one on patient-reported outcomes. And this doesn't mean that the primary outcome of your study has to be a patient-reported outcome. It provides advice if you're using a patient-reported outcome. So that was, as I was preparing this talk, I was like, wow, they have guidance there. And the checklist has additional sort of resolution in some of those areas. So I think they're really good things to look at. One of the things is there's CONSORT, but then there are also its cousins, the standardized reporting of observational studies in epidemiology, STROBE, and START, which is for diagnostic tests. And again, if you are in those spaces, like when I'm doing my little, if I looked at a STROBE statement back when I was doing my little logistic regression back in August of 2006, like, I don't know, like, oops, but the idea is if you look at this checklist in advance, again, it gives you a good sort of outline as to how you would be constructing the manuscript. And I think if you are doing an observational study, thinking about it from the perspective of here are methodologic areas that ought to be subheadings in your manuscript, and sort of mocking up a manuscript before you look at that data and having the idea of here are the methods I'm going to use. The idea here is reproducible research, reproducible and transparent research, that if somebody else was to go out and ask that question from an observational data set, or the same observational data set that you looked at, that you would get a similar answer. And the thing about diagnostic tests is also very helpful because it has a lot to do with the gold standard and how well are these being assessed. And again, I'm not going to go through all of the elements of these checklists because I had sort of resolved for this not to be a completely boring talk. But they're really good things. Every time I'm writing a paper like this or coming up with a sort of research design in this area, I pull this out, I look at it, and I use these to help structure the things that I'm considering as I go into the design of these things. Does that make sense? Okay, so then, I'm 5 minutes over. Okay, so acronym development. This is very important. There's a little bit of a balance in terms of developing acronyms, in terms of the timing. There's other considerations. Is it cleverness? Is it clever? Is there somebody else you can get to do it? Should you be doing it yourself? How much time should you really be spending on this? I mean, I thought we're scientists. Like coming up with cute acronyms probably isn't necessarily the best use of your time. And then if you do it in the pre-funding space, gosh, it's really too bad if that doesn't get funded and your acronym dies. So these are things to consider. So here's some of my favorites. ADAPT-IT, the Adaptive Designs Accelerated Promising Trials into Treatment. So this was a really nice acronym. That's probably my crowning achievement as an acronym, because both the acronym itself sort of spells out what the project was doing. So it's like, that's great. Tierra, this never got funded. We just started MRIing everybody in the emergency department and sending them home. But the Transient Ischemic Attack Rapid Assessment, which is a cool name, but Tierra really doesn't have anything to do with the TIA. ABASH, the adrenergic blockade after subarachnoid hemorrhage. I think I've told some of you this story of my own progression as a clinical trialist. When I was doing my master's degree at the School of Public Health at Michigan from 2007 to 2009, as part of the grant writing course, I wrote a grant to do a clinical trial, and I'm still trying to enroll my first patients in it, but that is fine, right? So it is what it is. Many of the pitfalls you've heard of, like I had to write an IND, I had to do this. Many of those things I went through. So, but again, this is an acronym though. If we just judge this as an acronym, it doesn't really have anything to do with the disease. So it's kind of a cool acronym, and that's why I've been continuing to try to get people in the study and change my primary outcome. I think when I get back, I'll have just a little bit more time at home. I think I'll be able to start getting people into the trial, but don't worry, it's registered on clinicaltrials.gov. So, I think in conclusion, overall from the course, do good research, publish everything. As people in my department joke, I don't sort of walk down the street without trying to make a publication out of it. Try to help people who aren't always making the best decisions if you can, providing good advice and hopefully some of the things you've learned. And one thing I really want to thank everybody here, because you've made a tremendous effort to be here, and I really appreciate the trust you put in us and that this was a valuable use of your time. Because I know that there's other people in this world that you'd probably rather be with than me, and that in terms of the prioritizations of your life, both the faculty and the students, you've taken time and effort and a part of your life and been here with us. These aren't all my kids. That would be insane. 60% of them are my children. The kid in the Minecraft shirt with the blurry face, he was born after I designed the ABASH trial, so he's now 5. Liam over here he has a Star Wars, so that's Luke and Leia and Darth Vader by the Golden Gate Bridge on his t-shirt. He was born on my last day of residency. Eve she's the only girl here, she looks rather tired, and she's 2.5. So I'm looking forward to getting back and seeing them, although they better be asleep when I get back to Michigan at 9. And I really want to thank you guys for being here with us. And those are my brothers, very cute kids too, Miles and Mateo. But with that, that's really all I have. And what we will do next is I'm going to give you guys some time to fill out the evaluations, probably until about 11:20. Like I said, be sure to click that button in the evaluation thing that says overall course evaluation. There's some room for some textual comments in various areas. Your evaluations of this course are what are going to make it better for us. In terms of the next steps, we as the core faculty are going to kind of think a little bit about,
I
yes?
just want to say, I thought we learned that free-form text format is bad
For case report forms, free-form text is bad. For course evaluations, maybe it's good. We'll see.
It's the best.
I think it's the best. Qualitative research.